Bismillahirrahmanirrahim. Today we are going to start with the pancreatic tumors and the tumor-like lesions. Among these tumor-like lesions, first of all, I would like to discuss a few things about the cystic lesions of the pancreas or associated with the pancreas. The pseudocysts, which account for about 75% cysts of the pancreas, Uh, they are formed as a consequence of acute pancreatitis. If you recall the complications of the acute pancreatitis, we talked about the fat necrosis, and the fat necrosis is immediately involving the areas surrounding the pancreas. So this pseudocyst formed in the substance of the pancreas is so called because it lacks a definitive wall. It is usually solitary and it may range in size from 2 to 3 centimeters. Formed, as I have said, in the substance of the pancreas or tissue surrounding it, it is formed as a consequence of the walling of the area of peripancreatic hemorrhagic fat necrosis surrounded by fiber tissue and granulation tissue. So the only thing which would be surrounding it, not a true membrane, but the granulation tissue and the fibrous tissue would be surrounding it, and the necrotic hemorrhagic material would be found in the lumen. This is rich in pancreatic enzymes. Most of the times, the patients who recover from the acute pancreatitis, after some times, if they still are complaining of the abdominal pain, and these cysts, they are usually discovered on ultrasonography, and they are associated with the persistent rise in the serum amylase. They may be seen in the lesser omentum as well. The pancreatic neoplasm, benign neoplasm, and the malignant neoplasm, only cystic neoplasm. The cystic neoplasms, they make about say 5% of the pancreatic neoplasm. Among these, the serous cyst adenomas and the mucinous cyst adenomas, they are benign tumors, but the mucinous cyst adenomas, they may be borderline malignant, and the malignant one, the serous cyst adenomas, they are usually the benign tumors. You must have read these serous cyst adenomas in the ovarian tumors, so they somewhat resemble those tumors. The serous cyst adenomas, they almost account for 25% of all the neoplasms, and the female to male ratio is about 2 to 1. They usually present in the 6 to 7 decade of life, and histologically they are composed of glycogen-rich low cuboidal cells surrounding small cyst having straw color fluid. This is the histological feature. You must remember that this is composed of low cuboidal epithelium cells which are surrounded by small cysts having a straw color fluid, as is there in almost all the serous cyst adenomas. Here you can see actual photomicrograph or the slide prepared from the serous cyst adenoma. You can see the cuboidal lining. I would delineate it for you. Uh, you can see here these are the cystic spaces, and these contain the serous fluid, which can be seen here as a fine eosinophilic material, and the amount of the stroma is very less. As you can see here, the glands, they are almost closely packed. The mucinous cyst adenomas, they usually arise in the tail or the body of the pancreas. Cystic spaces, they are filled with thick tenacious mucus, and histologically, as compared to the serous cyst adenomas, they are lined by tall columnar mucus secreting epithelium with dense stroma. The stroma is much denser here, and mucinous cyst adenocarcinoma, they may be pre-malignant lesions. How do they appear grossly? You can see here a big tumor which shows large cystic spaces which are filled with mucus and hemorrhagic fluid in it. So this is a feature of the mucus cyst adenoma. And the histologically speaking, you can see here the tall columnar epithelium, the upper border of which shows the lining of the mucus. This is the mucoid lining. and the base here is the nuclei, which you can see here. So this is the columnar epithelium lining with the surrounding dense stroma in case of mucinous cyst adenoma. The intraductal papillary mucinous neoplasms, these neoplasms are said to be the bona fide precursor lesion of the pancreatic carcinoma. They are divided into benign, borderline malignant, and frankly malignant. They mostly involve the head of the pancreas, while on the other side, the carcinoma can involve the body, head, or tail of the pancreas. These tumors, they mostly involve the head of the pancreas. Two features which differentiate it from the mucinous cystoma are the lack of dense stroma and origin from the main pancreatic duct. The mucinous cystadenoma, they usually arises from the small ducts, while this intraductal papillary mucinoplasm, they arise from the main pancreatic duct. The main pancreatic duct which joins with the common bile duct to enter at the ampulla of Vater. Here is a gross micrograph of the intraductal papillary mucinous cystadenoma. You can see here the papillary architecture, which is lined by the columnar epithelium along the stroma as well. The pancreatic carcinoma. Now, this is the very important topic from the university point of view as well. This is fourth leading cause of cancer death in the United States, most likely because of the recurrent bouts of the pancreatitis which occur there, and the use of the high protein diet and the alcohol they are most likely associated with. It is more common in males as compared to the females, and its incidence that progressively increases after the age of 50. Regarding its etiopathogenesis, the different factors which have been associated with this are the smoking, a diet which is high caloric value and high protein, especially the animal proteins, the chemical carcinogens, especially the beta-naphthalamines and the nitrosamines. The nitrosamines you are all familiar with, they are contained in the barbecue meat. Diabetes mellitus and the hereditary chronic pancreatitis, they are other factors which are associated with the development of the pancreatic. Among the molecular carcinogenesis, as is in other tumors, the most commonly altered gene I would mention, it is the KRAS gene, which is a proto-oncogene. It is most frequently altered, almost found in 80 to 90% in cases of pancreatic carcinoma. Similarly, the P16, again a tumor suppressor gene found on the chromosome, short arm of the chromosome 9, most frequently inactivated in 90% of the carcinomas. SMAD4 again is a tumor suppressor gene. It is also inactivated in about 55% of the pancreatic carcinomas. The normal function of the SMAD4 is suppression of growth and promotion of apoptosis. You must be familiar with it from your knowledge of the apoptosis. As you have read it, the P53, which is known as the guardian of the genome, in activation of this gene is seen in almost 50 to 70% of the pancreatic carcinomas. You must remember all these four genetic alterations because these are frequently asked in the university, at which are the genes which are altered or mutated in case of the pancreatic carcinoma. Now, as is the case in some other carcinomas, for example, the colon carcinoma, for example, the carcinoma of the cervix, they go through certain changes. Here, in case of the pancreas, they are known as pancreatic intraepithelial neoplasias, and the features are almost the same. You can see here that it goes through a certain series of changes. For example, pan in 1A is the one in which you see the dysplastic changes. The telomere shortening is there. The mutation of KRAS gene may be seen there. The epithelium becomes more and more dysplastic. The shape of the cell is changed. It becomes pleomorphic. There may be increased NC ratio, and progressively this would pile up, forming a sort of papillary structure, as we talked about the intraductal papillary neoplasm, and this is known as the panin 1B, and further progression with marked cellular pleomorphism, overcrowding, irregularity in the size of the nuclei. This is known as panin 2, and similarly so on and so forth. It goes through panin 3, where you can see the separate granular tissue lying in the substance of the pancreas along with more marked cellular changes, that is the more marked anaplasia, which means high NC ratio, more marked pleomorphism, and progressively this would lead to the invasive carcinoma of the pancreas. Morphology, talking about it, the grossly, most of the tumors, that 60%, they involve the head, 50% in the body, and 5% in the tail. The tumors involving the head, they come to notice first because of the symptoms associated with these. Because of the obstruction of the common bile duct, they may lead to the development of the cholestasis, and which causes different symptoms and signs. For example, the appearance of jaundice may be there, the features of the cholestasis may be there, along with a very important thing, which is the decrease in the body weight, decrease in appetite, and other features. In 20% of the cases, the entire gland may be involved. While similarly, the appearance, they are usually hard, stellate gray, white, and poorly defined masses. Because of the intense desmoplastic reaction or desmoplasia which this tumor evokes, these tumors are usually hard and poorly defined. As you can see here, this is a photograph showing you the pancreatic carcinoma, where you can see this whitish tissue is whole, the desmoplastic reaction. The histological appearance, the vast majority are ductal adenocarcinomas. What does it mean? That they form glands which may secrete mucin or may not. This depends upon the degree of the differentiation. The more a tumor is undifferentiated, the lesser will be this function, that is the function of secretion of mucus may be lost. Or in case of some the mucin secreting carcinomas, it may be there, but to a greater extent it depends upon the degree of differentiation. Two features which are characteristic of this tumor is the highly invasive nature and marked desmoplasia we have already talked about. This tumor is very invasive and it comes to attention because of its local and distance metastasis. The less common variants of these tumors, the acinar cell carcinoma, adenosquamous carcinoma, and the undifferentiated carcinoma with osteoclast-like giant cells. You must remember these names because they may not be in your exams, because these are of postgraduate session. Microscopically, here you can see the glands and the gland-like spaces surrounded by dense desmoplastic reaction. Here you can see these are the glandular spaces. This is the dense fibrous tissue surrounding that, infiltrated by the lymphocytes. So if we want to sum up the microscopic features of well differentiated carcinoma, the glandular spaces which are lined by irregular epithelium, the epithelium may be piled up, there is cellular pleomorphism, the increase or high NC ratio is there, and this is surrounded by a dense desmoplastic reaction which this tumor evokes. These are the histological features we should remember. Grossly, this tumor appear as ill-defined gross masses which are gritty in nature, and this grittiness is because of the excessive fibrous. Regarding metastasis, as I've told you, this tumor is locally and distally invasive. The locally pancreatic carcinoma may extend through the retroperitoneal spaces and traffic adjacent nerves, and this is usually associated with intense pain, which is characteristic of this tumor sometimes, and occasionally it may invade the spleen and adrenals, though the spleen is a very rare site to be involved in most of the metastasis, but it may involve the spleen and the adrenals, vertebral column, transverse colon, and stomach, and adjacent lymph nodes with liver involvement. And distant metastases, they principally are to the lungs and the bones. The clinical features, as I told you, that this has got an insidious onset. The tumors of the head of the pancreas, because of their obstructive nature, they obstruct the uh, uh, common bile duct or the pancreatic duct, and this is how they come to notice because of these jaundice and other features, the cholestatic features. The epigastric pain, first symptom with the weight loss, as I've told you that lot of emaciation and cachexia is there. Signs of common bile duct obstructions, that the patient they may present with jaundice, and more than 50% of the carcinomas of the head of the pancreas they come to notice with this. Anorexia, malaise, and migratory thrombophlebitis. Troisius sign. This is very important. This was the sign from which the Troisius, who recognized his own carcinoma, that there's some sort of thing which is going on. The migratory thrombophlebitis is characterized by thrombophlebitis, that is the inflammation of the veins in the different areas. The one area is involved and the other area, then the other areas. So the virtue node, they may be there. The lab diagnosis, the two markers for are the carcinoembryonic antigen and CA19-9. This is a gold standard tumor marker for the pancreatic carcinoma.